Hi, can you hear me, Evie? Can you hear me? Can you hear can you hear Okay, can you hear me? Just waiting a confirmation before starting. Okay, Bismillahirrahmanirrahim. Hi everyone. I hope that you can hear me all. Uh, okay, very nice to all my friends joining this live, being here today. Okay, and just to speak about a controversial topic or a new topic that is very important and everyone is interested in, which is the bioceramics. So we will start our presentation today. I'm honored to be part of this very nice and from all front of you. And I hope that you will find my presentation beneficial for you all. And of course, I'm happy to have the question at the end of the presentation and trying to answer most of your question about it. Of course, this nice gathering is under the organization of AT's company. So I would like to thank them for their professionalism and also special thanks for AV and for all the team of ATs, because we know that doing this, and I know that AV is all the time she is online. She is following all the speakers, making a test with all the groups. So I would like to congratulate her for the great success happened till now. And I would like, and I'm I would like, I'm sure, wonderful Damascus. You know, regardless of everyone is now, or uh, what is his all crisis Okay. Sorry, maybe I muted myself. I didn't intend to do that, but just hear my voice now, Evie. Can you please confirm? Can you please confirm that you can hear me now? Thank you. Very nice. You can hear me now. Okay, now getting into the point. The bacterial infection, we have to fight this bacterial infection in order to have a success in our root canal treatment. And then after disinfecting our root canal, we have to prevent the leakage that will happen later on because okay, thank you. Everyone is contacting me worldwide and they are confirming to me that everything is working good. This is very nice actually, because you are working live, so it's very nice to hear you, to understand that you are hearing me now in many areas of the world. So after disinfecting our root canal, we have to prevent the leakage, because if we disinfect well and we didn't prevent the leak, nothing actually. And leakage is prevented whether it will be from the periapical area or whether it will be coronally by applying a good final restoration. But as we know all that, our root canals, they are in the cross section, most likely they are oval. And our cataberca cone, most likely they are round. So we have spaces in between them. Many techniques has been advocated in order to have the 3D obturation by, for example, lateral condensation. That's been used for a long time with different sealers, or we can melt the cataberca and make warm vertical obturation like system B or other techniques of obturation. And we can obturate the remaining surface or the remaining area by bioceramics, which is the main topic of my presentation today. Lateral compaction, as you see now, we've been used for the warm vertical compaction, and also it's proven clinically with great success for a long time with long clinical trials. And actually we have so many great cases, good cases with ramification loops and anastomosis filled using these techniques, and we have a long time evaluation and we are satisfied with this technique. It needs certain equipments and it needs certain experience, so you can manage this and you will get this very nice results at the end. The traditional concept of the obturation depend on obturating the root canal most likely with the cataberca mass, and the remaining part will be filled with the use of the sealers. Okay, so the new concept of obturation or using the bioceramics is just a little bit different. Above or avoiding or against this concepts, or on the contrary, the main part, which is filling the root, and Berka cone will work in two jobs. I'm going to speak about them later. So we start to use the bioceramics being advised at the beginning of 2007, 2008, and we start using the bioceramics. So what is bioceramics? Let's have an idea about the bioceramics and what is component. According to American Association of Endodontics, we can understand that it is a pure calcium silicate cement. So, but without heavy metals. It is pure without heavy metals. So we can understand it is from the same. And the most important issue that it sets with hydration. So it needs moisture. If we don't have moisture, we will not be able to have good setting of the bioceramics. So we need moisture in order for a good set. And one of the most important properties of the material or as a bioceramic sealer or the premix bioceramic sealer is it has no shrinkage. It has no shrinkage it has no shrinkage, so we don't have any leakage. In some cases, or in some researches, they stated that it expand a little bit. So plus you can add a great flowability of the material. So it is very important to appreciate all these benefits. All these benefits will make made that we were able to use this obturation with a new technique, which is called the hydraulic condensation. The hydraulic condensation, which was advised discussing with him yesterday about this issue, advised in 2008, and it depends on the concept of using the sealer. And once you use the sealer into the root canal, you don't have to push the sealer till the end, maybe till the middle of the canal, and then you use the cataberca cone. Once you use the cataberca cone, this cataberca cone will push the bioceramic sealer, and then it will reach the remaining surface of the root canal. And they called it the hydraulic condensation. And we can know, or we also, it's named as a single cone obturation technique, but actually it could not be a single cone, as we discussed yesterday with Dr. Nasseh, because sometimes you may use many cones in order to push the bioceramics into to fill. Is not always a single cone. Maybe in cases it is a single cone, but it is not always a single cone. So we have to push the material using this cataberca. So the job of cataberca in this case is two. The first one is to push the material to fill the all the gaps in the root canal. And thanks for the flowability of the material for retreatment if we need it in the future. Actually, we have so many brands in the market about the bioceramics, premixed, or we can have some brands you can mix them two-based or powder and liquids. So different brands in the market. Maybe the middle of the canal, and here I am inserting a gataberca cone. This gataberca cone, I am pushing it slowly. You can see gataberca cone is so it creates of the canals or lateral canals. They were filled only by hydraulics. So hydraulics is pushing the material by the push or the use of gataberca. Before using the bioceramics, actually, I used to work on extracted tooth. I want to be sure the material is fitting, or do I have gaps? Is it because at the beginning I was not too much convinced that only applying the bioceramics will create the gaps. So I used to work on extracted tooth. I want to be sure that and here I'm applying the bioceramics and extracted tools, as you can see here, and till the middle of the canal. I'm withdrawing my hand. It's very important tip. When you apply this material, you put in the middle of the root canal, and then you withdraw your hand slowly. You don't have to push the material because you will have too much of the bioceramics. So you have to withdraw your hand actually. After that, I'm applying, as you can see here, the Gataberka cone. And the very important tip, when you apply the Gataberka cone, you have to insert it slowly. This is a very important tip. You have to insert it slowly. Otherwise, you will push too much material out of the apex. Then you cut it at the orifice of the canal using any heat source. Okay. After doing this, I make an X-ray for the case, and I can see this nice looking X-ray. I noticed that maybe I have a loop, which is a junction between one canals. So I was happy that even I didn't instrument this loop, but still it has good flowability. So I removed the extracted tooth after setting of the material, and I start to trim the root gradually to see what is happening, or to see if I have any gaps due of the root. Okay, so I start removing 1 millimeter by 1 millimeter. I'm trying to look for any gaps, but till now I can see that I reached the area of the loop. And once I reached the area of the loop, I was surprised that it was not a loop. It was a C-shaped canal. C-shaped canal. This C-shaped canal was filled with the bioceramics, even though you can notice this very narrow area, but the material flowability was good by using the Cataberca cone to push the material into this C-shaped canal. And I continue, I didn't find any gaps, so I started using it as a hydraulic condensation. Of course, we don't have our trial only. We have to look for literature. And according to literature, we see that the bioceramic sealer has good physiochemical properties, and it performs good in vivo, but in animals studies. And this is nice study in Journal of Endodontics 2018, tested the clinical outcome of the bioceramic sealer for monitoring about 2 years and a half, and they found the success rate about 90%. And in 50% almost of these cases, they have over-extrusion. And this is what happened when you start to use the bioceramics. So you will be confused. Is this over-extrusion will affect my my result at the end outcome? And they found that they didn't affect the outcome according to their studies. So after understanding the properties of the bioceramics material, suggested application according to the companies and what we can see every day, or according to the materials, they are advised to be used on a routinely basis. But for me, actually, I have to be more scientific at this point, and to wait more for longer clinical evaluation in order to say bravely that, okay, I can go for only using it, and I can shift, and I can throw everything I'm using and start using bioceramics for all cases. For me, in the time being, I can find that using it on a regular basis is something related to the operator. If you find the will for you to use the bioceramics, if you can afford, or your patients can afford to pay the bioceramic sealer, so you can go. And of course, you have to be good in retreatment in such cases if failure, although they are very, very limited. I'm going to mention one case at the end of my presentation, but you have to be aware of this. So on the other hand, I found during my practice with the bioceramics that we can use them with different applications. So I suggest the application, but because we don't have too much time, I'm going today to speak about only two applications, and I will list some clinical cases. So on a regular basis, as I told you, it's related to the operator. Till now, I don't dare to see shift for bioceramics, throw everything and start using bioceramics, although I can find very good and promising results. But in the time being, I advise you to use the material because it's easy, very easy, and very good flowability. And once you start using the bioceramics, you will fall in love with it and you will get good results. As you can see here, I'm applying the bioceramics from one canal and it's going out from another canal because of the flowability of the material. And it's very easy. Learning curve with it is not so difficult. You start using 1, 2, 3 cases and then you will go for it. And because of course some references, they say that this the bioceramics obturation, they are for lazy dentists. I don't agree with this, of course, but this can get some of that it is a really easy way of obturation the root canal. As you can see, I'm only here putting the gataberca, and I'm putting them into the easily we can at the orifice with any heat source. So this is on a regular basis, lower molar, nothing special. We have everything. We can do it in any obturation technique. But here I operated with bioceramics, and this is the recall functioning well. Another case with a lesion, as you can see here, we have a lesion. In such cases, I don't advise to go for periapical surgery because I think the lesion will not although the canal, it looks nothing special, no resorption, nothing special, but we can obturate it. I use the bioceramics. I applied the calcium hydroxide dressing until I get a dry canal. And once I get a dry canal, I obturated using a single cone bioceramic sealer. And you can see here, and this is a case after 10 months. I don't know, I'm not sure if I am covering the healing area on your screen, but we have bone formation. And if you go through a 2 years recall, you can compare before and after, and you can understand from this case that we have good sealing ability of the bioceramics, even if you are using a hydraulic or a single cone, as it is used in this case. Okay, this is the regular basis. I'm going to discuss now using the bioceramics in long and curved canals. Why we get benefit of it? We face everyday cases with long canals, especially in canine. Sometimes we face with 30 millimeters, 32 millimeters. And unless the crown is not destructed, we can obturate with one vertical obturation. But if we, for example, will take this a canine and we suppose that it is 30 millimeters long, and we want to obturate this root canal of the canine using the system B and obtura, for example, down, back, and backfill, continuous wave obturation. The tip in the best case scenario will reach and not more 22 millimeters. So I still have about 10 millimeters till the end of the root the canine. So imagine if you obturate such cases with canine. Example is the severely curved or abrupt curvature or the double curve. And not say that, okay, I do a continuation or the down back and backfill or the fast back and the thing, you will not be able to soften the cataberca at the very end. So in such cases, in the previous, it was advised if you want to obturate your root canal, you using a warm obturation, the best technique have the carrier-based obturator in order to fill the gaps of the root canal. So here, as you can see, a clinical case, it was an upper premolar. I suggest in such cases to go with bioceramics because we see that the bioceramics has good sealing ability, 3D obturation, even using a single cone. So the single cone will hold the bioceramics and will go till the end of the root canal. Here we have upper premolar, and we have destruction actually on the crown. And imagine after instrumentation, maybe we have about 30 millimeters long. And this is, and here I advise to go for bioceramics and to obturate the case as you can see here. You can see that in the palatal canal, I did a partial obturation. And this is why, because I remove some parts of Gataberka in order to be able to obtain. So how can I use the heat with bioceramics? I didn't use previously the heat unless I read this article. This article was published in Roots magazine by Professor Landulo and colleagues, and he mentioned the modified hot technique. And in this technique, he mentioned that in using the heat or the heat plugger with the ceramics, we are not intended at a very actually get better obturation, and then we can fill the remaining of the canal using the traditional technique. I will show you a case, and after this case I started using the you can see we have a necrosis lesion, as you can see here, and I did a root canal. It was to distal buccal and palatal canal. Everything was good, perfect in the buccal canal, but at the palatal canal, I noticed that I have something here. Although I see it is a single cone, and another, I advise you all do not cut the Cataberca cone unless you make an X-ray and you are sure that everything is working. Because sometimes you have over extrusion with the cage. If you didn't cut it, you can withdraw it. But if you cut it, you get the case will be more complex. So I noticed there's something, and I suspect that I may have here a lateral canal. So I pushed using the heat, and I make an X-ray using a heat, or modified hot technique was described in the article. Not using too much heat, short duration, and I'm not inserting the tip may, for example, go for 10 millimeters beyond the apex. We minimize the heat source of the pen we are using. Other benefits, I'm going to speak about the new devices. And then short duration, just kiss and goodbye. You don't have to stay 2 minutes. Use the bioceramics. It's called a modified hot technique, and of course we need a lot of research now. It's a new technique, but we still need in a research, and we want to know more and more about any clinical evaluation for this technique. And this is the same case after 1 year. You can see that I have a HEMB2, but I don't have any problem and normal BDL with the area that I use the heat. So in this case, it was very interesting. In the buccal canal, I used a single cone, and in the palatal canal, I use a modified hot technique, and both they both perform good results, and after 1 year recall. So I started using the heat, modified hot technique, the bioceramic sealer, as you can see in this case. I knew from the beginning that I have a lateral lesion. So here this is scouting of the root canal, and here I am using the heat modified hot technique. Again, I am applying the bioceramics in the middle part of the canal, and it's very important to see that I don't cut the canal. I don't cut and then stay in the same area. So you will push material, withdraw your hand slowly. And you, very important tip, another, you insert the gataberca cone, you have to insert it slowly also, because we don't want to push the material out of the root, and we don't want to have too much occlusion of the material. Then I use the heat source to cut. Kiss and goodbye, just 3-4 millimeters insertion, and then I go out the cutter, and then that's it. And this is the obturation of the material using the warm heat, and you can obturate the remaining of the canal using the other technique by fast fill, for example. And you can see different angulation. We can see the and the buffing of coming back to the article. We saw that but it didn't here. It's very important when we use a higher degree of heat, you can see the evaporation of the bioceramics happening. But if we can use lower amount of heat, that we don't have this bad influence on, as if we are applying the high heat. And this is very important aspect and benefit actually of the 80s fast back obturation device. As you can, obturation devices in the, which I prefer using, or even 150 when I obturate with hot modified technique using the bioceramics. Because I don't want to burn the bioceramics. I don't want to change the properties. As I told you, if it is used according to the article, I don't think, although to be more scientific, we still need more clinical. Meanwhile, I can tell you that I get better benefits of the fast back by getting lower heat, as you can see here, not to burn the bioceramic I'm using. Excuse me. Here you can see clinical side. Here I'm bioceramics, zinc oxide. I'm doing one vertical obturation, and then I'm inserting the. So in the bioceramics, I don't stay for this duration. You can compare now. The first case I showed you, it was bioceramics. Now it's zinc oxide eugenol. I don't stay for a long time with the bioceramic. I stay for a longer time with traditional obturation. And then the remaining part of the canal can be obturated with the fast fill. Also, stem, just show you that even if you have a very, very small amount, you still have ability to extrude the material. Then first you have to push on the bottom. You will start activation. You will start heating the material, and then it will reach. You can appreciate once it's blinking, so it's heating. So that you keep the, and then you extrusion. The very nice thing in this device that you will tell you that you have the taberca. The very nice is it is really economic when you less amount of cartridge you apply when you obturate with this device. Again, you reload the fast fill, and then you push activation. Then it starts heating. As you can see, very quickly maximum heat. Then by pushing, as you can see, the extrusion of the material is coming out, and it is softening gataberca. Clinically, with the same case of the zinc oxide eugenol, okay, we can see here, friends are sending some jokes. Interiors, here I have incisors with a lesion. We have a lesion here, and they were about millimeters. So in these cases, again, we have a long go for bioceramics. This one from the very beginning cases, So at that time I didn't get too much of the material. We have a sinus tract, we have a gataberca into the sinus tract, and this was the obturation. You can see that in all the four cases, you can understand which is the first one. Of course, this is the obturation of the gataberca, and this is the obturation of the sinus tract. Again, you can see this is the same case after 6 months. We come back, we can see the lesions, we can see the over obturation of the bioceramics. And again, this case was obturated using the Cerasil. And then you can see here we have a healing in the whole, almost the all cases, even if you have over extrusion with the material. So it's bioactive, biocompatible material, good to use it. Now, the second part of the presentation is going to speak about three techniques that I'm going to mention in this open abyss. I will try to go slow down more because I have some comments about being more slowly. Maybe some internet connection is not good, but here you can see I can use it with open abyss. We know that if we have wider abexes, and if we have a wide abex, and we can especially if they are more than 60 size, we advise to go for apical plug with MTA. Sometimes we don't have the MTA, sometimes we don't have the experience to deal with the MTA. So if you can get your getaberca cone with tuck back at the full working length, you can make the obturation using material. Here I we have undercut here, and it was filled with a single cone, so it has the ability to push the material. And this is the 6 months recall, and you can see the start of the healing at this area, and this is after 1.5 years with almost complete healing of this very large lesion. Another case, and actually I was discussing with the patient about the surgery or where to go non-surgical retreatment. The patient prefer not to go for surgery. We have over extrusion and we have wide or open apex. As you can see here, we have over extrusion of cataberca and open apex. We go with non-surgical retreatment. I remove the obturation material from inside the root canal. I will give you a tip. In such cases, I prefer to use the XB EndoShaper from FKJ, because sometimes if you are lucky, it will get the cataberca out. Here I apply the calcium hydroxide, and because we have symptoms and we have some oozing from the canal, and here after 2 weeks I was removing the calcium hydroxide. Very important to use the activation after removal. Here I am using the Ultra X with circumferential movement, and I use this with the wide canals, but in narrow canal I use the up and down motion. So circumferential movement here, and the canal now is very clean after activation with Ultra X. and you can see the apex at the end of the root. The Ultra X I consider one of the very interesting and very good devices they launched different beside the silver one they and use the gold one for broken file removal. Okay, as you can see here, here I can bend the tip, the blue tip, and you can abrupt curvature. You will be able to go beyond the curvature just a little bit by bending this tip. So it is recommended when you have a curvature, or if you don't want to use a metal, you can go for sonic activation. And this was the silver one, and also they introduced the gold one for broken file removal. I want to say some words about the use of Ultra X in a broken file, in removing of a broken file. It was made this very, very nice device for activation of a solution. I did some cases, I think about 25 to 30 cases of broken file removal. I used them with Ultra X. Relatively, I have some experience, can share my idea with you. It is good to try to remove the broken file in certain condition with Ultra X. If you are sure that you don't have wide canal after the broken file, because we know all that removing a broken file using the ultrasonics depend on the pulsing concept. So we need pulses in order to activate, to remove dentine all around, and then to activate the broken file in order to remove it. The Ultra X will give you continuous activation. So if the canal was wide, and for example, if the broken file was broken due to cyclic fatigue, and it is not too much engaged, and you can see on the X-ray that the canal beyond the broken file is wide, so I don't advise to use the Ultra X in such cases. But if it is well engaged, you can conservatively remove the dentine, although you can use it. I'm using with the U file because I can find the U file more quick in removing a tooth. It is of that the Ultra X didn't make any secondary fracture. On the contrary of U file, we have a lot of secondary fracture. So you have to know when to use them. But once you know exactly when to use the Ultra X, it's very good, very conservative, and you can remove less of dentine. And one of the most important application is this application. After I get the file loose, I use them to activate the EDTA. Because it is very thin, it will give space for the broken file to be able to the broken file in this. So we have to understand, you don't have to go for all cases, you have to study your case. Then when it is indicated to use the Ultra X, you can go. When it's not indicated, I don't advocate to use it. On the other hand, for me, I'm using the Ultra X on a regular basis for activation, and actually I can't go back and use another way, but I find it very, very beneficial in activation and the cleaning of a root canal. Here I did obturation using the MTA apical block, and then this is another advice. Here, we usually, if I go immediately, we wait for the set of the MTA, or we can apply zinc oxide eugenol. We obturate our root canal using the obtura. Here, why not to use the bioceramic sealer? The bioceramic sealer is from the same family of the MTA. So you can apply it, and then you can adjust to the minimum heat of the fast fill till, for example, 150, and you apply small amount of melted injected getaberka, and then you can use the obturation with the blugger. As you can see here, I'm condensing with the blugger. Then you can add more amounts of the obtura, and then you can gradually obturate your root canal with the sealer will be pushed, and you will have great connection between the MTA and the bioceramics, and you will have very nice looking obturation at the end. And you can get benefits of removing the obturation material in order if you need to make any post in the future. So we have this MTA and we have the bioceramics with obtura, and this is a clinical case. Here, I didn't go for MTA apical blood because I used to apply a calcium hydroxide for 6 months. You can see under the microscope, the tissue, the periapical tissue, they forming a matrix. I can inject the bioceramics over this material. You can see how it flows. You can see how it gets with the blood. Very compatible. And here I'm BC sealer actually. Here I'm using the BC sealer material from FKJ. As you can see here, I'm pushing the material and almost it is mixed with the blood. Then I apply the obtura. Here you need a learning curve. You don't push less. See, here I pushed just a little bit, and you can see the bioceramics is going around the obtura, confirming the contact between the bioceramics, which was with the, and you can see here we were able to obturate the undercut in such case, and this is after complete obturation of the root canal, and this is only after 2 months. You can see the healing. This is immediately after obturation, and this is after 2 months. It's very good according to 2 months because it has a good sealing and biocompatibility with the two structure. Okay, you'll tell me now, very nice. We saw a lot of cases, a lot of successful cases. You don't have any failure. In case if you have any bioceramics for a long time, they are very, very few. So what should we do? Now we are jumping to the problem that we are facing in literature, that treatability of the material. We have to admit that the retreat material, they are not easy to retreat. Let me give you an idea of a failure that happened with me. This case, when the patient came to me from Dubai, and he was in a hurry and he didn't have too much time, and also he had a breathing difficulty, and he came to me with a sinus tract, and he told me, please, can you treat this tooth? I told him, okay, I can treat. In this case, I didn't to apply the rubs. I told you, a breathing difficulty. I applied as usual, as so now I am dealing. You can see here I was pushing, and we have pus coming out of the canal. So we have failure. I have to understand failed, and on the other hand, I have to know what to do now. Usually, why the problem of having a failure when you are performing endodontic perfectly or in a good manner, you will have one failure, you can shift, but very beginning, or you think that I did obturate this case with Cerasil at that time, see what will. At the beginning, as you can see here, I removed the composite restoration. I used first a heat to soften the cataperca cone. Then I used rotary instrumentation. In this case, I was using the D3 from ProTaper. So I was able quickly to go in the middle of the cataperca to remove root canal. Here also Ultra X. You can see here Ultra X. You can use it with narrow canal by up and down main tip with wider tension. Here I'm using up and down motion. You can see dynamics. And here in this stage, I want to be sure set or not. I can see that. Okay, it is set. Up and down motion. I'm cleaning again till I can find after activation when I irrigate that I can see a pure looking irrigation. So I know that I almost totally removed the bioceramics from the wall of my root canal. And this is what I was able, it took me about I remember 8 minutes. The single cone with the bioceramics, it is not so difficult. It is difficult than, yes, it is possible, it is not you can see here, I apply a calcium hydroxide dressing 1 time, 2 times. The patient came every time came to me with a failure, sinus tract with a pain. 1 time I was applying a calcium hydroxide. You can imagine I have 2 areas. Now I have 2 sinus tracts. 2. Now I started with 1. Now I remove. I understand that now I may have something and the case is not responding to non-surgical treatment. Maybe I have to go for other alternatives. You can imagine this very nice. I was, when we have a sign, we the cataperca in order to see where it was. In this case, I was from the sinus tract. So we have a very, very bad situation of inflammation. So here I told the patient we did everything. We did retreatment. I'm injecting calcium hydroxide. I'm not able to overcome symptoms. So let's go for periapical surgery. So I did, again, a single cone obturation. And I go for periapical surgery. And guess what? See, when I opened the surgical side, I found the reason of failure. It was apical crack. Apical crack going from buccally to lingual. So this was the cause of the failure. I have necrosis. I have bacteria here that I was not able to disinfect, and this causing the failure. In such cases, I will trim. I will do a bisectomy until I can find no apical cracks. If I find so, I will continue by surgery of the tooth. So maybe we will change fraction. As you can see here, I looked under microscope and I can see the single cone surrounded by myself. Why to remove it? Great. I know that some with me, but I tried this case, good disinfection of the case and 3D obturation. So I just closed, and this is the X-ray immediately after the periapical surgery. And I referred it for pathology. Professor Dr. Nabil sent me the report, and it was a periapical granuloma because I thought I could have a cyst, periapical cyst, so this causing the failure, but we didn't have a cyst in this case. It was a periapical granuloma, as you can see here. And this is a long-lasting inflammatory process. So even we have a space, it is not a cyst, it's artifact, and we don't have any epithelial cells in this case. So it is a granuloma. So we removed it, and after 2 months, you can see that the sinus tract disappeared. after 2 months, and the X-ray after 4 months. Sorry, I don't have new because this case is new. I have the case after failure before surgery and the case after surgery, and you can compare that. We have a bone formation in this area, and we have normal soft tissue, even though I didn't do a retrograde filling. I depend only on the single cone and bioceramic. At the end, what do you advise ceramics again? If you want that you can do retreatment, be sure that you are doing your root canal perfectly, and you have to know that your patient can afford in order to get the benefit of this material and the easy of use. You can use heat, but the modified hot technique, and you have to take some devices that can deliver the minimum temperature, which is for bioceramics. And at the end, you can go for the suggestions that I made them, but unfortunately, I was not able because the time didn't allow only to speak about two, and we still have about 8 suggestions. Maybe we can each other in another online, because now we are staying at home. So many online conferences. You can follow me, and you can follow another cases of another application of bioceramic sealer. But at the end, and according to American Association of Endodontics, which was published in August 2000, I accessed on August. It was July 2009. They found the final statement or the advice that or the bioceramics is a promising material to be used in endodontics. So at the end, be sure to disinfect your root canal, and thank you very much for your attention, and I hope that you find patient beneficial for everyone. Now let's go for question. I don't know if what is going live, but I will check if Evie send me some question. Okay, we have some question from Dr. Arij. Okay, very nice question. Is the bioceramic sealer is, but as cases, and you can see that I had healing but without any resorption. But I don't know what will happen within time, but I think it's difficult to be resorbed. But we will wait and see. Things could be different. Dr. Marwan, can we apply the bioceramic sealer by coating Gataberka by it only? Okay, a clever question, because the bioceramics material is not cheap. It's expensive amount to use it. If you want to use the tips that they are delivered from the company, maybe you will have 15 or 20 canals. But if you apply, for example, a small amount or a mixing bag, and then you coat a Gataberka cone, you will of the you to remove the cone from the root canal, re-coat it again, and re-coat it into the root canal. So in this case, you will have more homogeneous, and still you can save more material. Dr. Safe. Okay, can we use it even inflammatory fluid? So you must read all the suggestions that I made. It was at the end. And sometimes, if I overcome the symptoms, the patient didn't suffer from some symptoms. We know that in each case, in each visit he came to me, still I have some exudate. So without the very small exudate, without the presence of any symptoms, and the patient, it's so far so good. In such cases, I believe we can apply the obturations bioceramics. We have to recall the case in case of go because it's question. We use bioceramics with warm compaction. I just mentioned, but you have to be the modified hot technique again. Shorter duration insertion, less insertion, and minimum heat. You have to go for devices that apply minimum heat. Saeed, could bioceramics plus Gataberka use of MTA to open apex, I mentioned a case when I start speaking about the open apex, but you have to make a tug back. Once you have a tug back at the full working length, so you can apply whether it is more than 60 size, whether it's 80. But if you have a tug back, you can apply. But again, you have to inject. Again, very, very important, يا جماعة. You have to draw your hand. Very important. You start injecting your hand. And the third tip, when you insert the cataperca cone, whether you coat it or whether you not, usually I don't coat it because I apply good amount into the root canal. You have to insert the cataperca cone slowly, because if you push it quickly, you will have over obturation. And be sure that the bioceramics will flow around the cataperca cone and will cover it. Okay, Riyad, Yusuf, how you clean the bulb chamber from the sealer? Very easy way. Just attach the scaler and apply some water, and you just rinse it. It will go out. The most easy sealer to be removed from the bulb chamber is the bioceramics. With water, you can remove everything. Dr. Ahmed, when you use the tip of heating, it is not feel of the advanced hydraulics, as I told, will more and sorry, will push the material more, and this will cause a push on sorry, a push on the material. I must stop sharing. Maybe I will be able to see me clearly. Okay, this will push the material so you may suffer from slight pain, but it's no problem. Even if you have over extrusion, I noticed that also you can check a lot in need for clinical evaluation in order to be sure that it works. Mustafa, when I use the MTA, so sorry, I skipped two. Does the extrusion of bioceramics here is associated with pain? I just answered before. How to avoid pushing all the taberca in very apical area while doing RCT. I'm sorry, but it is another. Let me go for related of the bios. Mustafa, when MTA bioceramics from Angelis, the patients feel pain during obturation until 1 week. Why? For me, I told you I'm not using the Angelis material. Maybe I used it one or twice. Now I'm using the Cerasil, I'm using the BC sealer, and they are performing very well. And be sure they will not cause any post-endodontic pain, or it will be in the minimum amount. Islam, what will happen if large amount of sealer above the apex? We have to be clear. We don't intend to push anything outside the body. This is a rule. But can we be able not to do so? We saw in the warm vertical obturation that it is most of the cases we will have buffing. Our main enemy, I will go is the bacteria. So once we control the bacteria, once we're able to control the bacteria, body is forgiveness with everything. The best case scenario is not to push anything, but if it was pushed out, it's better to have bioactive material compared, with non-bioactive material. So it's very important to understand this. We don't have to go beyond the apex. And another question: is it easy to retreat bioceramics filters? You go back to my presentation after I finish this live, and till the end of the presentation, you can see while using I think we will have in this conference and this webinars courses so many speech about broken file. At least I know my friend Dr. Zahir, he's going to speak on Friday. I advise you all to attend his presentation. We have, according to each case, a different indication. But if we want to go back for the use of Ultra X and the canal is wide, unless you will push the material, because you are not using a pulsing, you are using a continuous activation. So you may push, otherwise you can get benefit to be more conservative. And also very, very important, because the frequency in the secondary breakage in the broken file. But I'm using U file, I'm using 8025, another tips, and also I'm using the Ultra X. And when it comes to the activation, I prefer to activate the ATTA liquid with Ultra X because the tip is very small. When you activate Dr. Yusuf Adi, can we combine the bioceramic sealer for the apex and other traditional sealer for the rest of the canal? I don't agree to try over our patient unless we have any clinical trials. I don't agree. The case you saw that I applied MTA apical block, then I apply over bioceramics over it. They are both from the both. You can use them. I can't advise to obturate with zinc oxide eugenol, for example, and bioceramic sealer. What is the benefits? I don't get the idea unless we have a clinical study and we have certain for our patients. Our patients are not a guinea pigs, so we have to be aware of. And don't start. I told you I didn't start using the heat unless I read the article of Professor. I noticed that I have good results, and I don't advise, even though I have relatively ceramics. But as you notice, I didn't advise you at the end of my presentation to go for it as a road. I suggest to go for a certain application. But if you want to go for a regular basis, I did. You can go back for my presentation to have an idea. I don't know how the situation is going on Facebook. I'm really happy I've been with you today, that or not. Otherwise, I can now finish the presentation, and I hope that you spend interesting time. Sorry sometimes for the interruption in the internet. We don't have so much good internet. It's good enough to be with you today, and I hope that patient. And thank you again, ATs, for this kind invitation. And I hope that I add something. And I'm looking also forward to see you in the next session of the conference. Okay, thank you, everyone. See you soon. And until then, please stay safe.